going to use the Snelling chart, I'd have you do that first. And there should be a marking, Dr. Scafidi or somebody should have a marker so you would know 20 feet from that chart. But most likely there'll be other people getting exams here. So what I'm going to do, you can sit here, is use my Rosenbaum, and they have them here, Rosenbaum handheld screener. So what I'd like you to do, you normally wear glasses. I know that from taking my subjective information. I know that she's had some problems with nearsightedness and some blurry visions from studying. That's what she told me. Don't make up a lot of things. I've had this here, I'm bleeding from there. Okay. So what I want you to do is hold this 14 inches from your eye, cover up one eye for me with your glasses on, and what's the smallest line you can read? These are numbers, they're not letters.
The second to last one?
Well, just read them to me.
837826.
Okay, now cover up the other eye. Same thing.
837826.
Okay, all right. So remember, the denominator when you use this is what?
How far away?
14 inches, okay? Snelling is 20, this is 14. So if her line here, let's see, hers was almost 2025. But if she missed one, you would put 2025 OS minus 2, if that was the one eye, or OD if it was the right eye. Now, could you tell me what color you see here?
Red. Green.
Okay. All right. Could you take off your glasses and put them somewhere safe? Okay. All right. Thank you. So while I'm here, before I do confrontation, I'm looking at her eyebrows. They're within normal limits. I've cleaned my hands. I'm looking for any ptosis or lid lag. There isn't any. I'm going to also depress the lower conjunctiva area so I can see. They should be pink, not red. Her sclera should be clear and white. And I'm also noting the color of her iris. If it's not written down there, put it down as a thing. Hers are brown. Lower lids, I'm looking for two things. I'm looking for ectopion and entopion. What's the difference? Right, that's right. Ectopion, think of exit. It's when the lower lid inverts outward. And that can lead to problems with dry eyes. Entopion is when the lower lid encroaches inward and the little hairs on the lower lid become attached to the cornea. And they have to be surgically removed. Okay? So that's ectopion, entopion. Next I'm going to do confrontation, which is very subjective. You saw me do it. I did it with somebody here already, didn't I? Okay, so I'm not going to do it again, but you know what confrontation is. It's comparing your peripheral vision with the client's. We already did EOMs. Remember the H or the X, and we did convergence already. And we did direct and consensual constriction. I'm going to do it one more time so that you understand what you're doing. So I want you to look at the bridge of my nose. You start at the temporal area, and I'm looking to see how well her left eye constricts when I shine the light into that left eye. This is direct. Okay, indirect or consensual is when I shine the light into this eye, I look in the opposite. Okay, and so we can use the term perla, which we said stands for what? Right. So you should know what those letters, whatever ones you're using, what they mean. Okay, let me see here. What else is there before I do the fundoscopic? Oh, the Amsler's grid. No one mentioned that. Hopefully we'll have some of those grids out here.
You want one now? I have one.
Sure. You test one eye at a time with the Amsler's grid, where they focus in on the dot that's in the center. There should be no blurry vision. There should be no dark spots, no wavy, no waves. So I want you to do one eye at a time. I want you to focus in on here. Okay? And you have to rely on your client to describe what they see. So hopefully they see no wavy lines, no distortions, no dark spots. Okay? All right, and then we do the other eye as well.
Go to straight lines.
Okay, just straight lines. Anything else before I do the fundoscopic?
How long do you have them look at that?
Just focus for a second or two.
The cover on cover.
Oh yes, and the reflection, corneal reflection. You can't tell about opacities till you do the fundoscopic. But the cover-uncover test is so you can see if there's any nystagmus. So you can have your client cover up one eye and just kind of looking, now the other. Okay, and then for the corneal reflection, you're just going to shine a light in the cornea and you should see a reflection bilaterally. That's what the corneal reflection is. Cover-uncover is for nystagmus. You have a question?
For the corneal reflection, can't you also just like hold it away with the reflection of both eyes at the same time?
You could. I do one at a time, just in case there's a different response. One cornea might respond differently. It's very subjective. You're not going to make any
Okay.
diagnosis.
Yeah.
For the cover uncover test, that's testing for muscle weakness.
That's right. Sort of like EONs. You're again looking for any nystagmus. So if I did cover uncover, I could put a circle with a slash through it, meaning no nystagmus. Okay, so I would dim the lights. I already know, because I have my own otoscope, what the caliber I should have it on. You want to have it at the biggest circle. And all I'm going to be looking for at this level is seeing the red reflex. You're not nurse practitioners who have to look at the macula, okay, and the optic disc. All you want to see is a red reflex. It tells you that there's nothing blocking the light from your otoscope to the retina. That lets you know if there's any opacities. Opacities are like the beginning of cataracts, and they're sort of like bugs on your window when you're driving. You know, they're black, they're little black dots, and those opacities can occur any point in the lens, anywhere they can occur.
So would you see that in the red reflex, or is that like?
That's an abnormality. I'm saying you shouldn't see it, but if you should, you note it. You know where you see the opacity, like on a clock, right side between 5 and 6 o'clock. The trick with doing this is that when you're looking at your client's right eye, you have the otoscope right hand. Left eye, so what's your other hand doing? It's holding the eyelid up so that you can visualize appropriately. So yes, I'm going to look at her right eye first. She's going to look behind me. I can see the red reflex. I can also see her vessels, but all you need to do is see the red reflex. Again, I want you to look over my eye. Make sure you're holding the lid open so you can see what you're doing. And I can see the red reflex. Don't stay in there too long, it gets irritating. So now I can say no opacities, red reflex with the positive sign, bilaterally.
Should we know the color of the optic disc also, like the light?
No, you're not, and if you're a nurse practitioner student, I would say, yeah, you got to do that. All you need to know is I see the red reflex, there's no opacities in the lens. And using the scope appropriately in the right hand, using your other hand to hold the lid so you can actually visualize. That's all you need to do. Okay, anything else? Okay, then we'll do the ear next.